Welcome to Board Pearls. This is episode 1 of 4 of the GI in the Immunocompromised host chapter in the Special Populations and Acute or Supportive Care module. In this episode, we cover solid organ transplant GI disease, the 5-entity diarrhea differential narrowed by time since transplant, CMV colitis with its resistance pathway, Mycophenolate enteropathy, calcineurin inhibitor toxicity and its drug interactions, and post-transplant lymphoproliferative disorder. The transplant patient on calcineurin inhibitor plus mycophenolate plus prednisone presents with diarrhea, and the same complaint could be any of 5 entities at once. Cytomegalovirus, mycophenolate enteropathy, calcineurin inhibitor toxicity, post-transplant lymphoproliferative disorder, and Clostridioides difficile. The job is not to memorize the list. The job is to learn which of the 5 is in play, and the variable that does most of the work is time since transplant. The first month after transplant belongs to the surgeon. Surgical complications, line infections, hospital-acquired pathogens, primary graft non-function, hepatic artery thrombosis in liver recipients, bile leaks, and acute cellular rejection. The opportunistic infection differential has not opened yet because the recipient has not been on immunosuppression long enough for latent viruses to reactivate. The window from 1 month to 12 months is the peak opportunistic period. This is when cytomegalovirus disease emerges, when mycophenolate enteropathy declares itself, and when C. difficile cycles through the recipient population. Beyond a year, the differential shifts again, now to cumulative toxicity from years of calcineurin inhibitor and antimetabolite. Chronic nephrotoxicity, de novo malignancy including skin cancer and post-transplant lymphoproliferative disorder, late community-acquired infections, and recurrence of the original disease in the allograft. So before any test or scope, the question is how far out from transplant this patient is, because that single number reorders the differential. Now cytomegalovirus, because it dominates the middle window, and because the boards test it through one stem repeatedly. The risk stratification runs on donor and recipient serostatus. A CMV seropositive donor into a CMV seronegative recipient, called D plus R minus, is the highest risk combination. The recipient carries no prior cellular immunity to CMV. The donor allograft delivers latent virus into a host that cannot contain it, and reactivation produces primary infection rather than recurrence. D plus R plus and D minus R plus are intermediate, with reactivation of the recipient's own latent virus. D minus R minus is the lowest, with no viral inoculum on either side. Universal prophylaxis with valganciclovir 900 mg orally daily sharply reduced symptomatic disease. Duration scales not to the organ as a category, but to the immunosuppression intensity that organ demands and to the viral burden carried in the donor lymphoid tissue. Lung recipients run the longest course, 6 to 12 months, because bronchiolitis obliterans risk mandates ongoing intensive immunosuppression, and the donor lung carries the largest CMV-laden lymphoid mass. Heart recipients run about 6 months. Liver falls between 3 and 6. Kidney runs the shortest, 3 months, because immunosuppression intensity is lowest and donor-derived viral burden is minimal. The D plus R minus recipient takes the upper limit at every organ, and many programs extend to 12 months regardless of organ because that mismatch is the dangerous one. Letermovir is approved for hematopoietic cell transplant prophylaxis, not for solid organ transplant. A board stem that offers letermovir to a lung recipient on day 14 is offering the wrong answer. Valganciclovir is the agent for solid organ transplant prophylaxis. CMV immune globulin alone is not standard prophylaxis. Acyclovir covers herpes simplex and varicella, but has poor CMV activity and does not substitute for valganciclovir. When CMV breaks through, colitis is the presentation that tests most often. Fever, diarrhea that may be bloody, abdominal pain, weight loss. Endoscopy shows deep, linear, or punched-out ulcers, most commonly in the right colon and terminal ileum, and the appearance mimics inflammatory bowel disease closely enough that the wrong reading sends the patient to infliximab. The diagnostic move is biopsy from the ulcer base, not the ulcer edge. Viral inclusions concentrate in the granulation tissue at the base, because that is where the infected fibroblasts and capillary endothelial cells live. CMV immunohistochemistry on the base biopsy is more sensitive than hematoxylin and eosin alone, which catches only the classic owl's eye intranuclear inclusions and misses up to half of cases. Blood polymerase chain reaction supports systemic disease and is appropriate as a first test, but a positive blood result does not establish tissue invasion, and a negative blood result does not exclude tissue-localized colitis. Treatment is intravenous ganciclovir, 5 mg per kilogram every 12 hours, renal dose adjusted, for 2 to 3 weeks until viremia clears, followed by oral valganciclovir 900 mg twice daily until clinical and virologic resolution. The resistance story is one of the cleanest enzyme-to-drug links in transplant medicine, and it is worth understanding because the next-line agent follows directly from which mutation is present. Ganciclovir is a prodrug. It requires phosphorylation by the viral UL97 kinase to become active. UL97 mutations block that activation, and ganciclovir fails. Foscarnet is a pyrophosphate analog that directly inhibits the viral UL54 DNA polymerase without requiring activation, so UL97 mutations do not affect it, which is why Foscarnet is the answer for ganciclovir-resistant disease. UL54 mutations affect the polymerase itself and produce resistance to both ganciclovir and Foscarnet because both ultimately work at that polymerase. Maribavir, approved by the FDA in 2021, is an oral UL97 inhibitor at 400 mg twice daily. It directly inhibits UL97 enzymatic activity rather than requiring it for activation, so UL97 mutations that block ganciclovir phosphorylation do not necessarily prevent maribavir binding. Maribavir also spares the bone marrow because it does not produce the host cell phosphorylation intermediate that mediates ganciclovir myelosuppression. So the chain is clean: ganciclovir for sensitive disease, Foscarnet or maribavir for UL97 resistance, and a harder problem when UL54 fails because both major nucleoside pathways converge there. Mycophenolate enteropathy is the second commonly tested entity, and the trap it lays is histologic. The endoscopic and histologic pattern mimics Crohn's disease with segmental colitis and skip lesions, and the biopsy shows crypt distortion, dilated and atrophic crypts, eosinophilic crypt abscesses, and prominent crypt apoptosis. That last feature, crypt apoptosis, overlaps with the graft versus host disease pattern, which matters when the wrong host state is assumed. The discriminators from CMV colitis are negative CMV immunohistochemistry, negative blood PCR, and a history of recent dose escalation or a formulation switch or a new interacting drug. The discriminators from gut graft versus host disease are two: the host state itself, because mycophenolate enteropathy is a solid organ transplant entity, while gut graft versus host disease is a hematopoietic cell transplant entity, and the absence of skin or hepatic involvement that defines the graft versus host pattern. Mycophenolate enteropathy is dose-dependent direct toxicity to crypt epithelium from active drug exposure to colonic mucosa. So the management follows the mechanism. First line is dose reduction by 25 to 50%, because reducing exposure relieves the toxic stimulus. Conversion from mycophenolate mofetil to enteric-coated mycophenolic acid resolves symptoms in a substantial subset because the enteric coating shifts the absorption site distally and reduces colonic luminal exposure while still delivering systemic immunosuppression intensity. Azathioprine substitution is reserved for refractory cases because azathioprine is a purine analog with a different mechanism that does not produce the same colonic toxicity. Resolution takes 2 to 4 weeks once exposure is reduced, because that is the time frame over which crypt epithelial turnover replaces the damaged cells. Calcineurin inhibited toxicity tests as one specific stem, and it is worth recognizing the shape because once you see it, you cannot miss it. A stable post-transplant patient on Tacrolimus develops oral thrush or vaginal candidiasis, gets started on fluconazole, and presents 2 weeks later with tremor, headache, and acute kidney injury. The mechanism is fluconazole inhibition of hepatic CYP3A4. Tacrolimus is extensively metabolized by CYP3A4, so when the enzyme is blocked, drug levels climb into toxic range. The teaching is not the stem itself. The teaching is the drug list that does the same thing. The CYP3A4 inhibitors that raise calcineurin inhibitor levels include all the azole antifungals: fluconazole, itraconazole, ketoconazole, voriconazole, posaconazole. The macrolides erythromycin and clarithromycin do it. Azithromycin is the safe macrolide. The calcium channel blockers verapamil and diltiazem raise levels, while amlodipine and nifedipine are safer. Several hepatitis C protease inhibitors do it, voxilaprevir and glecaprevir in particular, and the combination of amiodarone with sofosbuvir produces severe bradycardia and is avoided. Grapefruit juice, imipenem, ceftazidime, metoclopramide, and cimetidine round out the list. The inducers, which lower levels and risk rejection, are rifampin, phenytoin, phenobarbital, isoniazid, chronic alcohol, and St. John's wort. Holding the line is simple. Every new prescription in a transplant patient is screened against this list before it is written. The other tacrolimus-specific toxicities are chronic nephrotoxicity, neurotoxicity with tremor, headache, and occasional seizure, hypertension, post-transplant diabetes, and rare thrombotic microangiopathy. Cyclosporine adds hirsutism and gingival hyperplasia. Both calcineurin inhibitors cause renal arteriolar vasoconstriction, afferent more than efferent, and that produces the chronic ischemic nephropathy that accumulates over years. When chronic kidney disease progresses post-transplant, the substitution of choice is an mTOR inhibitor, sirolimus or everolimus. They block T-cell proliferation downstream of interleukin-2 signaling without inducing renal vasoconstriction, so they preserve renal perfusion. Their own toxicity profile of hypertriglyceridemia, fluid retention, oral ulcerations, and impaired wound healing reflects mTOR's role in lipid metabolism, sodium handling, mucosal turnover, and the proliferative response wound healing requires. Recognizing why the toxicity profile looks that way makes the drug switch make sense. Post-transplant lymphoproliferative disorder is the fourth entity, and it has its own driver, Epstein-Barr virus. The proliferation arises when EBV-driven B-cell expansion outruns immune surveillance that the transplant immunosuppression has blunted. Incidence runs 1 to 20% depending on organ, with intestinal and multivisceral transplants highest and kidney lowest. The highest risk serostatus is EBV seronegative recipient of an EBV seropositive donor, the D plus R minus mismatch, and the highest risk patient is the pediatric recipient whose primary EBV exposure occurs after transplant in a heavily immunosuppressed state. The presentation is heterogeneous and often extranodal. Lymphadenopathy, unexplained fever, weight loss, and masses involving the GI tract, lungs, central nervous system, or hepatic allograft. The board typical stem is the lung recipient at 14 months with weeks of crampy abdominal pain, weight loss, melena, and anemia. Imaging shows a 5 cm circumferential ileal mass. EBV viremia has risen from undetectable to tens of thousands of copies. Biopsies show CD20 positive large atypical lymphoid cells positive for EBV in situ hybridization. The World Health Organization classifies these into 4 categories: early lesions, polymorphic, monomorphic, most often diffuse large B-cell lymphoma, and classical Hodgkin-like. Treatment is sequential, and the sequence is the teaching. First, reduce immunosuppression, often by 50% in collaboration with the transplant team, because EBV-driven proliferation is partially reversible when immune surveillance is restored. The recipient's own immune system is the missing break, and restoring even a portion of that surveillance kills some of the clones. Second, for CD20-positive disease, which is the majority, add rituximab. A risk-stratified protocol uses rituximab response itself as the prognostic biomarker. 4 cycles of rituximab 375 mg per square meter weekly, then consolidation determined by response. Patients in complete response after induction continue with 4 more cycles of rituximab maintenance, because complete response identifies clones still under immune-mediated apoptotic pressure that rituximab alone can sustain. Patients without complete response receive R-CHOP for 4 cycles, because non-response identifies more transformed clones with somatic genomic events that have escaped immune control and require cytotoxic chemotherapy. The stratification reduced toxicity compared to upfront R-CHOP for everyone, without sacrificing efficacy because the responders avoided chemotherapy they did not need. CD20-negative disease, the T-cell and plasmacytic and NK variants, goes to histology-specific chemotherapy plus immunosuppression reduction because rituximab targets CD20 and has no activity against CD20-negative clones. Surveillance with serial EBV DNA quantification in high-risk recipients allows preemptive immunosuppression reduction or rituximab before clinical disease emerges, with rising trends driving intervention more reliably than absolute values. BK virus is mostly a renal transplant problem, where it produces interstitial nephritis and ureteric stenosis with rising creatinine and detectable viremia. GI involvement is rare in solid organ transplant. Management is immune reconstitution through immunosuppression reduction because restored T-cell surveillance is the durable mechanism of BK clearance. Tacrolimus-associated thrombotic microangiopathy is the rare late complication where the answer is calcineurin inhibitor switch rather than plasma exchange alone, because the drug is the driver. Pull the solid organ transplant half together. The differential at every GI symptom is a 5-drug list, and time since transplant narrows it, with the first month surgical, the 1 to 12-month window opportunistic, and beyond a year the era of cumulative toxicity and malignancy. The mechanism teaching is mostly enzymes. 3 cypriot pounds A4 for the calcineurin inhibitor trap, where the azoles and macrolides and non-dihydropyridine calcium channel blockers push levels toxic. UL97 and UL54 for CMV resistance, where ganciclovir gives way to foscarnet or maribavir, and dose-dependent crypt exposure for mycophenolate enteropathy. Sitting over all of it, EBV drives the post-transplant lymphoproliferative disorder that responds first to reducing the very immunosuppression that allowed it. The next episode takes the other host state that hides behind the same word, transplant, hematopoietic cell transplant, gut graft versus host disease, where the donor immune system attacks the host, staging runs by stool volume, and treatment is corticosteroids first and ruxolitinib second. For the full chapter, the practice vignettes, and the topic tag question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 104 of chapter 34, and I'll see you in the next one.